Okay, good afternoon to you all. And earlier in the year, I had the pleasure of speaking at the IAS symposium in Zimbabwe, which had a focus on young people. And so I'm also delighted to be here again in Kigali, where the symposium is also focusing on young people. Thank you so much, IAS. Okay, so I'm going to. Oh, sorry, I'm not so used to this because I think I'm so loud. Thank you for reminding me. Okay, as you can see, so Jandiri is a model of differentiated service delivery for children, adolescents, and young people living with HIV, which started way back in 2004 with a group of only 6 adolescents who named it Jandiri. It's a Shona term meaning accept me as I am. This was a response to the increasing availability of treatment for children, adolescents, and young people living with HIV, but the lack of psychosocial support and community support to address their complex emotional, historical, and psychosocial issues. We hoped to promote both their psychosocial and treatment outcomes. Jandiri's differentiated service delivery model is in the where and when of art and also provides differentiated support at in adherence to these children, adolescents, and young people to improve the quality of life. And at the heart of Jandiri are young people living with HIV. I think he has said the presentation in bulk, so I'm just going to run through because what Jandiri is doing in Zimbabwe, it has been adapted and adopted also in Rwanda. So cats, as you can see, these are HIV positive individuals who are 18 to 24-year-olds. And then, like he said, CAT stands for Community Adolescent Treatment Supporters. They're based at the health facility and they manage a caseload of children, adolescents, and young people between the health facility and the community, and thus forming a vital bridge between the two. And Jandiri supports Zimbabwe's Ministry of Health and Child Care to ensure children, adolescents, and young people are found and linked early and retained, thus fulfilling the 95, 95, 95. So CATS conduct index case finding in the homes of and clinics together with other community cadres in Zimbabwe have what we call the CCW's child care workers. And then they ensure that these children are linked and they are initiated on art and they give that peer support, ongoing information is given, and then they identify issues with red flags that require further assessments, and then they refer. Again, they work with community cadres from social protection to strengthen this identification and response for these children. So like I alluded on my previous slide, these are the roles of cats across the 95, 95, 95. And I'd like to comment on this slide that the level of support which is provided by cats is differentiated into standard and enhanced according to the psychosocial needs of these children. It's more of like the stable and unstable clients, but the adolescents refuse. Like, you cannot call us unstable. So it's standard and enhanced. The Jandiri program and CATS has been adopted by the Ministry of Health and Child Care and integrated within 51 districts in Zimbabwe with 1,114 CATS providing care and support to 59,753 children, adolescents, and young people living with HIV. So we have had the honor of working with other countries who have expressed interest in this model. Jandiri has now been adopted or adapted in Eswatini, Mozambique, Namibia, Rwanda, Tanzania, and Uganda. Currently, there are 328 cats or yaps providing differentiated service delivery to 10,452 children, adolescents, and young people living with HIV in that region. And it has been incredibly exciting to work with other young people from across the region. So, we cannot talk about anything without data. It really supports our work. And as you can see from the outcomes and the data, that over the years, we have used program data and research evidence to demonstrate the impact of our work and that the model is effective. Then CATS-led index testing, as you can see, we have reached 90%, and the positivity rate is at 7%. And 97% of those children, adolescents, were initiated on art, and 99% of those children, adolescents, were suppressed after 12 months on art. And across the country, 77% of children, adolescents, and young people were virally suppressed. So this actually has improved from national data, but we are still working on it so that we fulfill the 95 reach. And also, a 2-year randomized trial found that adolescents receiving Jandiri were 42% more likely to be virally suppressed compared to those receiving standard care alone. Then, what have we learned from 2004 up to now? Okay, we've learned that Jandiri works, as I've just shown you in the previous slides. We've also learned that a multi-component layered peer-led intervention is effective in promoting both HIV outcomes and quality of life amongst children, adolescents, and young people. We know that government leadership and coordination is absolutely critical for this model to function, be it in Zimbabwe, be it in other countries where it has been adapted or adopted. We also found that it was necessary to define the model by developing standardized guidance and implementation material in as much as it's being implemented in 51 districts, multiple funders, but our tools are standardized. We know that training and mentorship and supervision of peer service providers needs to be integrated within the national systems if they are to be accepted, integrated, and also supported. And this is very key. Like my colleague has alluded to earlier on, this can be done without the young people, and they are at the heart of Jandiri, of planning, delivering, monitoring, and evaluation of services. We know that data captured and reported on does not reflect the enormous impact which peers are making, but we need to make ways to demonstrate and recognize the incredible contribution that they are making towards the 95, 95, 95. We also have found over the years that we need to use program data and research to provide the much needed evidence for peer-led models. And finally, we have found it to be important to carry out, to cost our services, and currently we are running a cost-effective study. And Murakoze Chane, I hope I got it right. Thank you.